Good evening, everybody. Hello and welcome. I'm going to get the program going a little bit sooner, since everybody is here. Great to see all of you here, and thank you for making the effort to come down for this event. Dr. Wetstein, if we can ask you to please come and join the panel, we would appreciate it. We're also going to do a Phillies chant at the end of everything, so don't go anywhere until we send good vibes for the Phillies series against the Astros. All right. Folks are good? Excellent. All right. So again, thank you for being here. I'm Hossein Borgai, one of the thoracic medical oncologists here. And I know many of you, but not all of you personally. And again, I'd like to really emphasize how important it is for us to have you all here. This is your program, this is your evening, so please interact with everybody here, ask your questions. And don't be shy about telling us what we're doing well, what we're not doing well. We'll always want to hear that. And any burning questions that you have regarding lung cancer. The Phillies we can't predict, but lung cancer we can help you with. I'd like to start the program by asking everybody to participate in a moment of silence to honor all of those that we've lost to cancer. So please join me in this moment of silence. Thank you. Thank you, everyone. I'd like to thank our exhibitors that you see behind us for their support. It is because of them that we can offer this program to all of you here. Our gold exhibitors are AstraZeneca, Caris, Exact Sciences, Foundation Medicine, Gordon, Lilly, Natera, and Tempus. Our silver exhibitors are Boston Gene, Bristol Myers Squibb, G1 Therapeutics, Genentech, Janssen, Jazz Pharma, Novartis, Pfizer, and Regeneron. We also like to thank the advocacy organizations for their partnership: American Lung Association, Go-To Lung Cancer Foundation, Lung Cancer Research Foundation, Longevity, Right Heart, Breathe Easy, and the White Ribbon Project. I'd like to ask for a round of applause for all of our supporters. We're supposed to have cards on everybody's tables. You see any cards? You can write your questions, or I want to work on rectifying that issue. Make sure you have cards on your table so you can ask the questions. In the meantime, if you have a question, please raise your hand and we're going to come to you. So with that, I would like to pass the program to my colleague, Dr. Jessica Bauman, who's going to open the forum and the program tonight. Dr. Bauman.
Hi, everybody. Thank you so much for being here. It is thrilling to be here for the first time in 3 years. Lisa and I were just talking about the last time we were here in person was 2019. So we've been through a lot over the course of the last 3 years, and it's just a wonderful thing that we can come together this evening. So it's great to see you all in person and all your smiling faces. We have a fantastic panel with us today from all different specialties that are affiliated with lung cancer, both from the clinical perspective as well as from the research perspective. And so I'd like to start first with our panel introducing themselves and just giving us a little bit of background of who you are and what you do on a day-to-day basis here at Fox Chase. We'll start with Lisa.
Hi, I'm Lisa Atkins. I am one of the oncology...
And wait, hold on one second. You have to get really close to the mic so that it can carry through the room.
Okay. I'm Lisa Atkins. I am one of the social workers here who follows the lung cancer population, and here for the support piece, the emotional support, and connecting to resources along the way.
Thanks, Lisa.
Lisa's great. My name is Carolyn Zwislak. I'm one of the physician assistants here at Fox Chase in thoracic medical oncology. I also am a tobacco treatment specialist here and work with our tobacco treatment program, which offers both telehealth and in-person visits here at Fox Chase.
Thanks, Carolyn. Nick?
Hello, my name is Nick Boder. I'm one of the thoracic oncologists here at Fox Chase. I see patients both here at Fox Chase as well as at Temple University Main Hospital. It's really a pleasure to be here today, and my particular research focus is in lung cancer among never smokers, and I do a fair amount of translational research with many of our laboratory colleagues here at Fox Chase.
Thanks, Nick. Danish?
Hi everyone, I'm Danish Ahmed. I'm one of the pulmonologists here at Fox Chase. I work very closely with the thoracic team, the thoracic oncology team, taking care of patients who need diagnosis, extra tissue, or other issues that we can manage from a breathing standpoint in lung cancer.
Thanks. Dr. Burrows?
Good evening. My name is Whit Burrows. I'm one of the thoracic surgeons. I've been here for 2 weeks, but I'm very excited to be here. It's a wonderful place. I can see that. Obviously, I deal with surgery for lung cancers.
My name is John Wetstein. I'm a cancer research doctor here at Fox Chase. I'm the director of our Cancer Epigenetics Institute. I actually came to Fox Chase in 2019 from Mass General Hospital and Harvard Medical School, and my lab studies basically how does your DNA change and ultimately provide cells to become resistant to therapy or not respond the way you want them to.
Thank you all, and welcome. So we're going to start our evening with Dr. Boder speaking on targeted therapy in non-small cell lung cancer.
Thank you. Thank you, Jessica. Once again, I do want to say it's truly a pleasure and honor to be here speaking in front of all of you today. Like Jessica said, my name is Nick Boder. I'm one of the oncologists here, and today I'm going to speak to you guys about the role of targeted therapy in non-small cell lung cancer. And so this is kind of the general treatment algorithm that all thoracic oncologists kind of follow when they first meet a patient who's unfortunately been diagnosed with stage 4 lung cancer. And the thing I really want to highlight more than anything is the importance of upfront molecular testing. Historically, lung cancer really was kind of grouped based off the way it looked like under the microscope or the histology of the lung cancer. But in recent years, that has dramatically changed, where it's not only the histology that's important, but really kind of the molecular, genomic, DNA characteristics of the tumor itself really plays an important part. And the reason why that's the case is because it really dictates what we do as far as treatment. And so if one were to find one of these special molecular mutations or targets, it opens the door for potentially highly efficacious targeted therapies. And so what you can see from this pie chart here is that there is a number of different molecular mutations that we look for in patients who are diagnosed with non-small cell lung cancer. And you can see certain mutations like EGFR, which are typically found in patients with no smoking history, or mutations like KRAS, which are actually found more often in patients with smoking history. There's a wide array of different type of mutations. In addition to EGFR, KRAS, there's other ones like ALK, ROS1, NTRK, and many others that us as oncologists, it's really important that we figure out early on whether or not those mutations are present. And like I said, the reason really being, first and foremost, is the fact that it does potentially open the door to highly effective therapies if one of these mutations are found. And in fact, many of these therapies are actually oral therapies, pills that can be taken at home, and so one doesn't need to get a port. One doesn't necessarily have to have an IV place to get an infusion in the infusion room. These are medicines that one can take at home. In addition to that, there's been a lot of excitement about immunotherapy, as there should be. It really has been a game changer and has led to a subgroup of patients to potentially even be cured of their lung cancer because the immunotherapy works so well. However, unfortunately, immunotherapy does not seem to work very well in patients who have tumors with one of these special driver mutations, which makes it all the more important that we look to see whether or not these mutations are present, not only to choose the very best targeted treatment for these patients, but to also to make sure we're not giving them immunotherapy incorrectly as their first treatment. In addition to that, if one were to give immunotherapy prior to one of these targeted therapies, if one had a tumor with one of these mutations, it could actually potentially lead to toxic side effects once someone stopped the immunotherapy and were started on a targeted therapy instead. And then lastly, another reason why it's so important to look for one of these targetable mutations is because it also opens the door for a number of potentially exciting clinical trials for patients with one of these tumors that have one of these targetable mutations. And so as you can see here from the timeline, there's been an absolute flurry of activity over the last 10 to 15 years. I know it's very small and a bit of a distance from all of you, but what all those individual boxes represent are FDA approvals of targeted therapies. And you can see on the right the table of all the molecular tumor alterations we now look for in patients with newly diagnosed stage 4 lung cancer. And so there's a wide array of them along with associated FDA-approved targeted therapies. In addition to the stage 4 setting, there's been exciting developments as far as the use of targeted therapy in earlier stage lung cancer. And in fact, what this clinical trial schema shows are the results from a trial called the ADORA trial, where they actually had patients with EGFR mutated lung cancer who got surgery and then received what they call an adjuvant therapy with a drug called osimertinib for 3 years. And what they actually found was that with treatment with this targeted therapy after surgery decreased the chance of the cancer coming back for those patients. So ultimately, what are we doing here at Fox Chase? I mean, we very much practice what we preach. We do upfront molecular testing on all patients with a new diagnosis of non-small cell lung cancer. And in fact, we have an in-house panel that actually reflexes. So if a patient were to get their biopsy done here at Fox Chase, even before they meet me or one of my oncology colleagues, those special molecular testing is already being done behind the scenes. And so we are able to get our answers quicker and then ultimately are able to start treatment even faster. So once we have those results, we're able to choose the very best treatments for our patients. But in addition to that, the other important thing to highlight about getting this molecular testing early is the fact that there are a number of different clinical trials that are open to patients with one of these molecular driver mutations. And this is just a small handful of trials that we have open here at Fox Chase. And what you can actually see here is that we have trials for many of the different molecular mutations that we find in patients. Thank you very much, everyone, for your attention.
Thank you so much, Nick. We will have some time in a few minutes when we have our whole panel open to questions that we can ask Dr. Boder, Nick Boder, more questions about this. I think we'll switch now to Dr. Danish Ahmad, who will be talking a bit about his specialty of interventional pulmonology.
Thank you, Dr. Bauman. And good evening, everyone, and thank you for being here. So my name is Danish Ahmad. I'm one of the interventional pulmonologists here at Fox Chase. I see patients when they come in with any problems with their breathing, or if there's an abnormal scan or imaging that shows something that needs to be done from a pulmonary standpoint, or if our oncology or surgery colleagues have asked us to see the patient. So what exactly do interventional pulmonologists or the pulmonary division at Fox Chase, what can we do for patients when we see them? So how do we see patients? So the patients usually come to me in one of two ways. The first way patients come to me is when they have some symptoms, whether there's shortness of breath, there's a cough, there's some sputum that they're bringing up, and that's something that they need to have worked up. So that's in usually the first way that I see patients. Another way that patients can present to me is that there is something abnormal that has been seen on a chest X-ray or a CT scan, and they need that to be worked up. So just to orient ourselves, there's that picture of our lungs on that PowerPoint slide right there. As you can see, our heart is in the center of our chest. We have our right lung and we have our left lung, and there are airways that let us breathe air in and out from our lungs. Additionally, you see those little dots, which are green and blue and orange and red. Those are lymph nodes that are placed all over your chest and that are present in the rest of your body as well. So when we are talking about abnormalities, we talk about abnormalities within the lungs, we talk about lymph nodes that can have some abnormalities in them, or sometimes we even talk about abnormalities around the lungs. So sometimes you can have fluid buildup around the lungs in patients with lung cancer, and those, in those cases, we call that fluid pleural effusion. So those are a few of the ways that we end up seeing patients. And there you can see a CT scan as well. And on the CT scan, on the left side of your image, you see that there's an arrow showing us an abnormality within the lung, and that's a lesion in the lung. And the other CT scan, you can see that there's an abnormal lymph node, and that's the red circle. So these are some of the ways that we are looking at patients and seeing exactly what the issue is. So what can I do when patients present to us and there's a question of, hey, there's something going on in the lungs, there's something going on in the lymph nodes, or there's fluid around the lungs? So the first thing that we can talk about is a procedure called a bronchoscopy. And there is the bronchoscope right there. It's a small, thin tube. It has a camera at the end that we use to go in and take a look. So for this procedure, bronchoscopy, we usually keep patients under general anesthesia. So our anesthesiologists are actually very good at keeping patients comfortable and safe during the entirety of the procedure. Once patients are asleep, we're able to put that bronchoscope through their mouth into their lungs, and they don't need any incisions to be made, anything like that. Once the bronchoscope is in the airway, we can go where we need to go. Another good thing about the bronchoscopy is that it's an outpatient procedure. So you come in, you get the procedure, you recover from the procedure, and you go home. And not only do we have the ability to biopsy the lesions in the lungs, but we can also biopsy these lymph nodes. So the biggest question that comes for us is, hey, we see something abnormal on the CT scan, or we see something abnormal on some other imaging, whether that's chest X-ray, and what can we do? How can we figure out what it is? And that's our job right there. So in special circumstances, when there's something abnormal in the lungs, sometimes we use robotic-assisted bronchoscopy. So it's one of the cutting-edge tools in our field that we have access to at Fox Chase, where we can use actually a robotic platform to get to abnormalities within the lungs. We actually use CT scans that are performed and use the information from the CT scans to create a GPS that the robotic system tells us to go exactly where we need to get these samples needed for our oncology team, as Dr. Boder was mentioning regarding molecular testing. Another thing we can do is look at the lymph nodes in the center of the chest. So this is another way to perform bronchoscopy, in which we actually use an ultrasound to look at the lymph nodes in the chest and take biopsies of the lymph nodes. It's also a very simple procedure done in the same manner, and patients are able to go home. Lastly, I did want to switch gears and talk about fluid buildup around the chest. So in some cases, when patients are suffering from lung cancer, they can have fluid buildup around their lungs. Oftentimes, that can cause shortness of breath, that can cause difficulty breathing, that can cause a cough. And in those situations, we can drain that fluid and help patients feel better. That procedure is called a thoracentesis. In some cases, the fluid may come back. And if the fluid comes back a few times and the drainage is not enough, we can also place a small tube that is on that picture right there. Thin, flexible tube that can be under a dressing, and you can go about your day, not have to worry about anything or be tethered to anything, and drain at home as needed every few days, and that's called a catheter. And those are some of the ways we can help with breathing issues as well. And I want to stop there and just thank everyone for their time, and please feel free to come up and ask any question you may have. Thank you.
And so with that, those are the two formal presentations that we had tonight. But what we really would like to do is open the floor for questions for anybody who has things that they'd like to ask any of our clinical as well as our research professionals here. And I'm happy to have some questions sent up to me if you want to write it on a piece of paper and bring it up, or if you want, we also have a microphone to bring around to the audience, so you can also raise your hand. So I think that, so we'll start with a question from one of the audience members who sounds like there's some concern about toxicities of radiation therapy, and specifically if there's anything that this person can do to heal better. And I think we can think about this question a couple of different ways. One is just in general, how do you recover from the toxicities of treatment? And I'm happy to turn that to Carolyn and Nick to answer that question. And then if it sounds like more specifically for this person that they've had some ribs that are broken and seem to be not healing. So if there's anything in particular for that, how you would approach that.
Sure. So with respect to potential toxicities and side effects from radiation, I mean, certainly I defer to usually our radiation oncologists who I know aren't having here presence today, but working very closely with them, I know they start by making sure they choose the proper dose and make sure they don't radiate necessarily more than they necessarily have to. So in that sense, when they're only targeting the particular areas that have cancer and try to spare healthy tissue, that does ultimately limit the amount of toxicity and side effects that comes along with radiation. In addition to that, there are a number of kind of supportive measures that we can provide. And so as medical oncologists, we work very closely with our radiation doctors, and there's a number of different settings where it's very much a multidisciplinary approach to treating lung cancer. So in particular, what they call locally advanced lung cancer or stage 3 lung cancer frequently involves a treatment modality that involves both radiation and chemotherapy. And so the oncologists work very closely with the radiation doctors to not only effectively treat the lung cancer, but also to try to limit the potential side effects and toxicities. And that involves not only frequent clinic visits, but additional fluids if necessary. If one were not to be eating or drinking enough, in rare cases, sometimes you can put in feeding tubes. The radiation doctors might also offer kind of additional kind of skin creams if there's some skin changes or skin toxicities, as well as other type of kind of oral medicines, because frequently one might also develop something called like esophagitis, where you get a lot of kind of reflux and burning in the throat. However, there are some medications that we can provide that kind of help alleviate some of those side effects. So I hope that kind of answers some of the questions, but I mean, ultimately it comes down to frequent clinic visits, calling in when there's issues, and letting us know as providers that if you're having problems tolerating radiation, chemotherapy, or any other treatment that we're providing, that we know right away so we can give you the very best support and additional kind of supportive measures to help you get through the treatments.
Thanks, Nick. Carolyn, would you like to add?
Yeah, I agree with absolutely everything that Dr. Boder said there. As far as what patients themselves can do, simple advice is what we tend to give, right? Stick as much as you can to your normal routine. Things, especially during, radiation and treatments along that modality, making sure that your nutrition is adequate is key. That helps you heal better. And to that effect, we do have nutritional support as well here at Fox Chase who can step in and kind of help us in those situations as well. I'm trying to think if there's anything else. I think that's all I had to add.
Okay. Yeah. Well, thank you. I would love to have, do we have the microphone? We'll have somebody come over and ask. Unless you can shout. Well, give us a minute.
Here we go.
Dr. Ahmad. You mentioned robotics in that bronchoscopy, if I'm pronouncing that word correctly. Why do they use the robotics for that?
So this is a changing field, but one of the reasons people have started looking at robotic bronchoscopes is to see if we can get better answers for people. So obviously one of the things that we always want to make sure is that when we actually do a procedure for any patient, we get them an answer. So the hope is that the robotic bronchoscope may be able to get us more certainty that we are getting you a real answer and not having decreasing the chances of those false negatives that we talk about, where we do a biopsy but we get a negative result and we're not 100% sure if that's actually a true result or not. Additionally, with just the ergonomics of the robotic bronchoscope, it allows us to use different tools that we were not able to use previously as well. The doctors, actually, we are the ones driving the robot. So it's not that the robotic bronchoscopy is being performed by somebody else. It is actually the physicians, the pulmonologists who perform the robotic bronchoscopy. It's a different tool is what I would say. So just like a bronchoscope is a tool, the robotic bronchoscope is another tool. It can't work by itself. It still needs someone who knows exactly how to use that instrument.
Thank you so much. I think also just as a follow-up to that, which I'd love to have Dr. Burrows comment on, is some of the advances in surgery with robotic techniques as well.
Sure. So you may have all heard the terms of VATS. So VATS stands for a video-assisted thoracoscopic surgery. That's using a video camera to do the surgery as opposed to looking directly at the lung and manipulate the lung directly. We, in that situation, are the robotic arms to kind of dovetail into what Dr. Ahmad just said. In terms of, those are instruments that we hold in our hands, and through small incisions and using a video camera, we guide our movements. So in robotic surgery, it's the same size incision, small incisions, but we're using the assistance of a robot, or robotic arms, and we control those arms. And what that allows us to do is have better magnification. So it's an order of 10-fold, so we can really get down very close to our subject, the lung, and all the vasculature that goes to the lung and the windpipe that goes to the lung, all the things that we have to divide to remove that portion of the cancerous lung. The other advantage is that we are limited to our motions of our hands, and those are transmitted to these instruments. And the robotics allow us to have infinite more movements and fine movements. So it's just an adjunct. And what it provides is a more, the equally invasive of an incision so we can largely do everything we do open, and sometimes we have to still do the open, but it allows us to do it in the most minimally invasive way.
Thank you very much. It looks like we have one more question here, and then I also have a couple that are written down. Yep, the microphone's coming.
You were talking about a lot of the targeted gene therapy for non-small cell. Are they doing the same thing for small cell?
So great question. Dr. Boder, you want to take this?
Yeah, so it's a very good question. Unfortunately, small cell is clearly a very aggressive disease, is frequently, our treatment options are generally more limited. In addition to that, unlike in non-small cell lung cancer, where we've identified a number of these special targetable mutations in which we have potentially highly efficacious therapies for them, small cell, it unfortunately is not the same sort of cancer. And There's certainly no FDA-approved kind of targeted options for small cell lung cancer. However, there is, I can guarantee, active research, including, research being done here at Fox Chase in the laboratory space, looking to see for kind of better treatment options for patients with small cell lung cancer. But to answer your question, at least in the current kind of treatment landscape, unfortunately, the answer is no, and it's a very much an unmet need.
Thank you very much. One of the questions that we have on cards is for Dr. Wetstein. Can you talk a little bit about what you do in the lab and how that potentially translates to clinical trials in people?
Yeah, it's a good question. I mean, a lot of people want to know, like, what is it like in a lab? Like, how does that actually translate to what you see or experience? And basically, if you think about it, like in our lab, for example, we'll use cancer cells or normal cells, and basically what we're asking in our cells is, how do they stay who they are? Like, how do they know who they are, right? Because every cell has 6 feet of DNA in it. So whether it's your liver, your lung, your skin, they all have 6 feet. But each one of those, how it uses that same information looks different, functions different. And what we're interested in the context of cancer is trying to understand, how is cancer changing that program of how you read the DNA, because that's like your text of information, so that the cell can grow better, it can evade therapy, it can change its visibility so immune therapy does or doesn't work. In the case of small cell, it can change its differentiation, like what type, how does it really look? Like, what's its fate? So we study, how is that DNA, how is that controlled, that environment, how do you leverage that? How do you biomark, come up with a target that clinicians, pathologists can use to stratify the tumor, like the mutations? How do we then develop new therapies? Because there's a whole slew of novel therapies that are coming forth to target these various areas, so that we can either kill the tumor, slow it down, make it more visible, just by changing how the DNA is organized inside that cell. So labs use all kinds of tools. We use fancy sequencing technologies. We use mouse models. There's people that isolate proteins, specifically the things that make it happen, and look at who they are or what's happening to them. The whole idea in a lab is to understand, how does the watch work? So think about it. If you have a broken watch and you're just looking at the watch, you don't know what's happening. So the best way to figure it out is you open it up. And you can find if there's a piece missing, a gear missing. You can find out if the battery's not there. So research labs are basically taking things apart in a layered way, figuring out, is there something unique that tells us a story? Is there a target? Then we collaborate with our clinical colleagues, and then what we do is then establish ways to develop a marker so we can look clinically, or we have a new drug target. And I'm very fortunate in doing these types of studies, because when we discovered this new gene several years back, and that new gene is very relevant to small cell. It's very relevant to a number of other cancers, and now we know that we need to target it. So now there's new clinical trials that are actually being launched, and in fact, one will be being launched here. And so by understanding what's going on inside, you now have new insights what to do. And we live in an era where information is fast, the techniques are quick, there's novel resources and collaboration. And I will say, the main reason I came to Fox Chase was, it's a nimble ship. We all work together. We have a team here that I can't brag enough about to say, because the clinicians respect the scientists respect the clinicians, we respect all staff that use all the different approaches. So a research lab is not just a lab, just something that sits off in the corner. When it's used appropriately, it's bringing that information to our clinical connections so we can make a difference in everybody's life.
Thank you so much. Yeah, it looks like we have a couple more, and I also have a couple up here. Microphones coming, and then I think you also have a question? Okay.
Yes, I'm just wondering what you're seeing on the horizon for earlier detection for lung cancer, and also for genetic testing for those loved ones in the room and beyond that are worried about heredity.
So I'm happy to, what? Well, I'm going to keep deferring to the panel. Lisa wants me to answer some of these questions. I think I would love, Dr. Burrows, I'd love for you to comment on earlier detection if you'd like to, both Dr. Burrows and Dr. Ahmad, about potentially resources of early detection, and then we can ask Dr. Boder maybe a question about the genetics.
Well, this is perhaps the most progressive thing in surgery, actually. It's because we can detect cancers earlier. You might have heard this lung cancer screening trial. So we put people at risk for lung cancer through a series of CAT scans to identify cancers before they're clinically evident. So we know that lung cancer is known as the silent killer, and excuse the term killer, but the idea is that it's silent because, generally speaking, it doesn't have symptoms until it's very late. And at the later stages, I can't safely remove it, or it's beyond our ability, it's not localized just to the lung tissue where surgery really has its impact. So what we've recognized is that we can possibly do smaller surgeries when the cancer is that less advanced. So that's really the junction between early detection and screening by CT scan and its impact on finding cancers earlier that we can safely remove.
As Dr. Burrows was mentioning, the biggest thing that we think about with early detection is who is at risk. So we've been trying to figure this out for the longest time, that what population of patients are the ones that are highest at risk for lung cancer. And we know that smoking is the biggest risk factor for lung cancer. So for early detection, there is a screening program. There's a lung cancer screening program which looks at patients within a certain age group, anyone older than 50 years of age, who has smoked over a pack per day for at least 20 years. And those are the patients who have a higher risk of cancer. And in those patients, there's recommendations that we do yearly CT scans. The good thing about these CT scans is that they're actually known as low-dose CT scans. So they actually use less radiation than the other CT scans that people generally get, but they have enough of detail for us to look at it and see, is there something that we're worried about? And we do that on a routine basis to keep an eye on things, as Dr. Burrows was talking about the silent aspect of lung cancer, so that we can find abnormalities within the lungs, whether those be nodules in the lungs, lymph nodes in the lungs, or anything else that we need to address before it becomes clinically evident.
And
Thanks.
I would just like to add, I mean, one can actually look at this based off of two types of lung cancer. There's smoking-related lung cancer, and then there's never smoking lung cancer. And what Dr. Ahmad and Dr. Burrows was kind of referring to more is the smoking-related lung cancer. And there's been amazing kind of public health efforts as far as increasing CT scan screening, like they were referencing. And there's been a number of trials both here in the United States as well as overseas that have found that it makes a difference, that there is a survival benefit with early detection and being able to resect smoking-related lung cancers early. However, it's the never smoking lung cancer where we're having a bit more difficulty, because these patients have never smoked yet unfortunately still have developed lung cancer, and so we don't know who necessarily needs the screening. And in reference to your questions in regards to if there's some sort of genetic test or is there some sort of kind of family genetic predisposition, to be perfectly honest, we haven't identified one. There have been a number of studies looking at that, in particular Asian countries, which actually has a greater proportion of patients with never smoking lung cancer. And they've done a number of different genetic studies, and they haven't really found any firm links with some sort of particular cancer predisposing gene. We've all heard of like BRCA mutations and how that's associated with breast cancer and ovarian cancer and things like that. And the hope was that we'd find potentially something similar within never smoking lung cancer so that we could help those patients who may be at increased risk. And there are a handful of very, very rare mutations that we have found that's associated with never smoking lung cancer risk, but I can promise you it's a very small minority of patients that gene is actually responsible for why they develop lung cancer. For everyone else, we don't know what the reason is. And not to toot our own horns, but we're doing research on that here at Fox Chase on a daily basis. And in particular, what's really kind of jumped to our attention, which many of you kind of may have heard of me speak about in prior years, so forgive me for having to say it again, for you guys having to hear me say it again, but there actually seems to be a lot of evidence suggesting that the way estrogen and how it's metabolized by someone's body may be associated with lung cancer risk. So ultimately, perhaps that may be a screening tool in the future as well to see whether or not how someone metabolizes estrogen or particular estrogen-related biomarkers, how that may be associated with never smoking lung cancer risk.
Can I add one more comment? I'm sorry, I'm here.
Of course.
Right. So some of the exhibitors that we have here tonight actually are working on a pan-cancer blood test. You asked about what's in the horizon and what could possibly. So that is actually a huge area of investigation, a simple blood test where you can identify actually multiple malignancies. So it's not lung cancer specific at this point, but there are quite a lot of areas of investigation trying to, again, identify a signal based on a couple of tubes of blood. So I think we're waiting to see some of those results, and hopefully Fox Chase will be participating in some of those, but there's actually a lot of interest in this area, early detection.
Thank you so much. Can we bring the microphone to this man here? We'll start here and then go back there.
Hi, my question is really in two parts. The first one is, I think we've all heard that in almost many cases, sooner or later under a chemotherapy regimen, the cancer cells become wise to it and it stops working. And I think I'm curious about what's the mechanism by which it figures out how to wise up, and how do we keep it from getting too wise? The second part of my question is completely different, and I'm not sure it's appropriate, but it has to deal more with pain management for those that have bone or metastasis in the bone and spine of these various cancers. And other than the normal drug regimens that are prescribed and so forth, are there other activities at a patient level or other therapies that are maybe out there to help in that arena? That's the second part.
Great. Well, thank you. I think we've been joined. Dr. Borgai's decided to join us at the table. So I'm gonna make him answer the first question.
I had a chair here. I thought I was just floating out there.
I'd love for you to comment on sort of the first part of his question, which is how do cancers become resistant to, one, targeted therapies, but also I think there's a real question about the same kind of question to immunotherapy. And what is the research in that area right now, and how are we going to fix that problem?
All right, we have time. Right? It's only time. So it's different for every treatment, right? And quite frankly, I don't think we quite understand all of the reasons why a cancer cell might become resistant, and some of the work that Dr. Wettstein and Dr. Boder and some of the other investigators are doing here actually is designed to try to figure out why some of the cancer cells become resistant to whatever particular treatment we're giving them. We also identified resistant cancer cells to radiation. You kind of think there's nothing more powerful than radiation sometimes, but there are areas, there are cancers that could become resistant. So the mechanisms are different. For targeted therapies, what we do understand at this point is that new mutations come up as you're using a particular targeted therapy against a mutation. The argument is whether these mutations are already there at the beginning, but they're at the low frequency, at the low level, and we just can't detect them with our currently available standards, or is this really something that happens as a result of the treatment-related resistance? And there's been a lot of back and forth on that, but we do, for some of the targeted therapies in the world of lung cancer, like EGFR and ACT, we do understand that new mutations come up, and these mutations are just enough different than the original that make the targeted therapy that we use ineffective against those cancers. So these targeted therapies have to have the right target to go at it. So the slightest change can cause that to become a problem. We recognize resistance to chemotherapy. That's a completely different mechanism. There are actually a number of different identified factors. For example, there are some cancer cells that can actively pump the drugs that we use out of the cell so that the drug doesn't actually have an option to work on the cancer tumors. And for immunotherapy, we basically have very little understanding as to why some tumors become resistant. That is a very new area of investigation for us. We classify tumors into tumors that are basically refractory to immunotherapy from the get-go, meaning that you try the drug and it just doesn't work at all. And that's a completely different set of issues. And then there are tumors that originally, or at least for a while, respond to immunotherapy, and then resistance happens. And to us, those are two different biologically separate processes. Very little understanding. There are 1 or 2 genes that have been identified as potentially being responsible for some of these alterations. So it's a very nuanced and complicated area. And I would say that our understanding for targeted therapies, at least some of them, is a lot more advanced. But for immunotherapy, is still very premature, very early, and a lot of work has to go on that. I hope that provides some understanding. Thanks.
Thanks. And then in terms of your second question, which is management, sort of novel ways to approach pain management, Carolyn, I'd love for you and perhaps Lisa to offer insights into how we approach that here at Fox Chase.
So pain management is obviously it's a big issue for many of our patients, particularly when it affects things like bone stability, like you were asking about. We approach it from a very multifaceted view. There are the traditional pain medications, opioid pain medications, along with, NSAID medications, things like Advil, Celebrex, that sort of thing. If you're able to take that, can be very effective for that. We do work very closely with our orthopedic colleagues for stabilization of, say, if it was a spinal, vertebral body or something that we can stabilize in that fashion. That can help a lot with pain control as well. We work with our radiation oncologists to radiate areas that might be growing or causing pain. And we also are very fortunate to have a great supportive oncology team here at Fox Chase, who always have an extra trick up their sleeve beyond what we're familiar using with, in our day-to-day practice. So I think, we have a lot of different ways that we can go after this, and it's certainly, it's something that affects most of our patients at some point, right?
There's actually also some interesting evidence that for patients who have a new diagnosis of stage 4 lung cancer, that integrating our supportive and palliative care team early in their care, even if they don't necessarily have pain, but can help tremendously in terms of quality of life, in terms of mood, and even in terms of sort of support for caregivers as well. And so just as we want to deliver the best treatments that we can to our patients with cancer, we also the supportive care is just as important. And that team is incredibly helpful. We also have, just as we have clinical trials in multiple different areas of novel treatments, we also even have a clinical trial right now that's looking at 2 different ways to deliver supportive care through a telehealth version as well as inpatient or in-person interactions. And so we're very interested in all of these different types of research as well as how to support our patients as best as we can. One other question that I want to bring, or a couple of different questions. We'll start with one, which is for a diagnosis of stage 4 non-small cell lung cancer, if someone is treated with immunotherapy and has completed 2 years of immunotherapy and is in a position where they have responded well, what happens after that? Nick, you know I'm looking right at you.
Yes, I'd be happy to answer this question. So as many of you guys are probably already aware, some of the early clinical trials looking at immunotherapy, for the patients who did really well, the way the clinical trial kind of dictated things was that the treatment actually would stop after 2 years. And so there's this very early phase 1 trial called Keynote-001, which looked at this immunotherapy drug, pembrolizumab, and what they actually found, and now enough time has passed that we've actually been able to follow some of these patients for many, many years now. And what we found was that there was a subgroup of patients, even after completing immunotherapy treatment after 2 years, years down the road, 5 years, 6 years, they were still alive, doing well without any evidence of disease progression or disease recurrence. That's the amazing thing about immunotherapy. It's really one of the only treatments that we have to offer as medical oncologists that can lead to those long-term durable responses where patients with stage 4 disease, we might actually dare say that they may be cured of their disease because the immunotherapy has worked so well. So to kind of answer your question, that does indicate that perhaps for some patients, if they've been doing really well, there's no evidence of any disease progression, that after 2 years we can consider stopping the immunotherapy because some of these early clinical trials indicate that many of these patients continue to do really well over the long term without getting additional treatment. And I'm lucky enough to have some patients who are in that position. But ultimately, it's a conversation between me and the patient. I think that would be what most oncologists would say. And it's a bit of a nuanced conversation, and ultimately it's a joint decision that's made between the patient and the provider, because certainly if a patient wishes to continue treatment beyond 2 years, that's certainly not unreasonable either. Ultimately, I think it is kind of a shared decision made between the oncologist and the patient.
Yes, we've got a question right up here.
He's been waiting.
Oh, sorry.
Yeah. I'm like, he's been waiting.
Sorry. I promise you're next.
The gentleman just mentioned, what's that thing? Estrogen. My wife had to start taking that in like 4 or 5 after something happened, you know. Could that have caused her lung cancer in 19 since she was on some estrogen like 14 years earlier? Or maybe she was on it a couple years back then. I forget how long she was on it.
So Nick, you want to take this one?
Happy to. No, that's an excellent question, and I certainly don't want to raise any kind of additional concerns or lead things to be kind of misunderstood. But certainly, I could see where your question comes from, and that's actually a very good question, and actually a question that has been examined quite extensively. Now, what we know with breast cancer, yes, hormone replacement clearly does increase the risk for breast cancer. However, for lung cancer, hormone replacement, estrogen supplementation, like in the case you just described, there actually is not a clear link. There's been probably numerous studies on this over the last 15 to 20 years, some showing a relationship, but also a whole bunch of studies not showing a relationship. And looking at all these studies as a whole, I think ultimately, as far as estrogen supplementation, hormone supplementation, as far as pills and things like that, there is not a conclusive link between that and lung cancer development. So I think what you're describing, I think we can say pretty comfortably that it's probably not related to lung cancer development.
Thanks.
Dr. Ahmad, I'd just like to ask earlier.
Oh, hold on. Can you put up closer to your, no, the microphone. We just couldn't hear you. Sorry. There we go.
Dr. Ahmad, may I just ask you, in your presentation, you had mentioned that you have the ability to drain fluid from around the lungs. I have a situation where I do experience some swelling. So I assume that's fluid. If you do have fluid around your lungs that is a concern, will you have symptoms?
So swelling is, so it's important to think about where the fluid is. So you could have swelling in your hands, you can have swelling in your legs, and that kind of swelling can just be limited to your hands and feet, or your legs and your arms. In some cases, if there is swelling that is a an indication of fluid, extra fluid in your body, there can also be extra fluid in your lungs. But that fluid generally is within your lungs, and you cannot drain fluid from within your lungs. In those situations, we give patients pills if needed for shortness of breath to kind of get rid of some of that fluid. If you develop fluid around your lungs, then that can cause shortness of breath. All of us have a few milliliters of fluid around our lungs. That's completely normal. So until you develop enough fluid that it's actually causing symptoms, we don't generally drain that fluid.
It's not a concern if you don't have symptoms.
No, it's not a
Right.
concern.
Okay, thank you.
Thank you. Other questions? Here we go. Hold on. Microphone's coming.
I heard of this product called Clear Lungs. It's an herbal formula. Any comments on something like that for people I'm not saying, even for people whose lungs are good, is it something you've heard of, or does it have any benefit?
Dr. Ahmad?
Clear lungs.
I have not heard of this herbal formula or remedy. As a general rule, I would say that unless you have underlying lung disease, if your lungs are normal, you don't need any medications or any supplementation for your lungs. So you don't need specific vitamins or anything like that, specific herbal remedies for your lungs if they're normal. If you have underlying lung disease, then there are medications like inhalers or other medications that we can give patients. There's not enough information about herbal supplements to help with your breathing. So as a general rule, I would say that I would steer away from those products.
Thank you.
But you can buy them on Amazon. Sorry, I was Googling it. Dr. Google. One more question.
I was just wondering, I was diagnosed many, many moons ago, and I don't think they were doing any genetic testing back then, because I've never been told that I had any genetic differences that I should be aware of. Is there any reason why I should get tested at this point?
Dr. Borgai, would you like to take this one?
I would say, honestly, at this point, if everything is going well and there's no evidence of disease, I don't see any immediate need for genetic testing. Since if I heard you correctly, the diagnosis was many years ago, and thankfully the disease hasn't come back. But since the standards have changed, it is something that we can consider, but having the information alone isn't necessarily going to help without any clear evidence of disease at this point, at least in my view. I don't know if Dr. Boder or others have other opinions.
I agree exactly with what you said, and even if, a second cancer were to develop, we would want to run genetic testing, particularly on that cancer, not a prior one, to make decisions on a current treatment.
Completely agree. Yep.
I do think one thing that comes up sometimes with genetic testing is we have become broader over the course of the last many years in what we're testing and how much we're testing. And so there's a possibility that you are on a current therapy and your tumor was tested, say, 5 years ago. We are now testing in different ways. And so if there was nothing that has come up previously, there are sometimes in some situations where we actually recommend you be retested with some of the newer panels, because there can be new and other things that are detected because our technology has gotten so much better over the course of the last several years. Another question from the audience, which is, what happens and what do you do if you've been prescribed some kind of maintenance therapy, whether that's a chemotherapy maintenance or an immunotherapy maintenance, but you've had really significant side effects and haven't been able to take that? What happens? What do you need to do? Nick?
Well, I think that's where it becomes really important that you speak with your provider, because ultimately, all these decisions, are made in conjunction with your oncologist and your provider team. Frequently when someone is suffering from significant side effects and things like that, many times we may not know, and we can't help you, and we can't make the proper adjustments or do what we need to do in order to kind of help best treat your cancer, as well as kind of making sure you're able to tolerate the best you can, and ultimately that doesn't impact your quality of life in such a negative, significant way. So I think ultimately, if that is the case, I think first and foremost is speaking with your provider directly, whether it's calling into our phone triage line. We have a wonderful set of nurses who answer all these calls and get these messages to us, or at the next visit, if you feel like it can wait, definitely speak with your provider. And there's ways where you can potentially alter the dose, or we can provide other type of supportive measures to make sure you're able to kind of tolerate the therapy as best as possible.
Other questions? Thank you. Lisa, this one's definitely for you. Are there staff members who can support my family? Things such as a support group or other ways to support this diagnosis as well, and family members.
Yes, there are plenty of resources in that direction. We're fortunate enough to, I'll take this off, fortunate enough to have oncology social workers who are here to provide individual and family counseling to patients and their loved ones. And loved ones can be anybody who's important to you. So, and that's a free service that we do offer. We've been doing a lot of telehealth and Zoom counseling because, COVID, and it has made it much more convenient. In the past, we have had lung cancer support groups, and unfortunately, just over time and just people's schedules, it has not been a popular group. So we're always looking to see what patients would like. I am up to hearing what patients are asking for and what everybody feels they need. But we are all licensed clinical social workers who are here to help support all of you.
Thanks, Lisa. And I would also say as well that is another role of our supportive and palliative care team, that they also can offer a tremendous extra layer of support in addition to your oncology team, in addition to our social work team. So there are certainly different people who are available. Other questions? There's one other question, I think one last question, potentially. We'll see, unless someone has another burning question, which is going back to this question of genetics and screening. This is someone who has a family member who's had multiple family members, including parents as well as siblings, who have died from lung cancer without necessarily any genetic markers. And some of these were smoking-related, or maybe smoking-related lung cancers. And so how does a family member who hasn't necessarily been smoking approach what they need to do? Is there something that they need to be concerned about for early detection? Are they at increased risk in any way? And how should they approach this for their health? Danish? And then maybe Nick.
So I think this is a challenging question, and I have had patients come and ask me this question as well. The risk factors that have been defined for screening purposes are somewhat limited, and they don't have a good answer for that. So in this situation, as Dr. Boder and the rest of the panel have mentioned, it's always a good point to have a conversation with your provider to really talk about what could be the next steps and go about from there.
And I completely agree. And in addition to that, I just kind of want to add more broadly, just being your own advocate. And I think, we all should have, whether we're inflicted with cancer or not, we should all have primary care doctors that we should be seeing on a regular basis, getting our health checkups and everything else. And so if one is cancer-free, but then develop a cough or something else that persists, or something just doesn't feel right, I mean, speak with your primary care doctor, and they can order the appropriate workup. I mean, certainly in the cases of never smoking lung cancer, that's a frequent story that we come across, is that sometimes a patient may have a nagging cough or losing weight for unknown reasons, and they're not exactly sure what the cause is, but they're otherwise young and healthy, and they think, oh, it's probably nothing. Or they may even speak with their primary care doctor, and the primary care doctor says, oh, it's probably nothing because you're otherwise young and healthy. But I think we all know our own bodies. You all know your own bodies. If something doesn't seem right, really advocate for yourself. Speak with your primary care doctor and get that additional workup that's needed if there's something that doesn't seem right and is truly bothering you.
So, one more question.
So what are the percentages of never smokers that you're seeing here right now? And what is the approximate age group?
Yeah, so very good question. So here at Fox Chase, and this is actually mirrors what we typically see most across the United States, is about anywhere from 15 to 20% of the lung cancer patients we see have no smoking history, yet develop lung cancer. And that's a significant number. I mean, when you think about it, there's 250,000 new lung cancer cases diagnosed every year in the United States. 20% of that is a very large number. And that's just here kind of in the East Coast and at Fox Chase. If you look at other parts of the United States, especially areas that might have a larger population of patients who are of Asian descent. So we have colleagues at Stanford where close to 40 or 50% of the lung cancer patients they see are actually never smokers just because they have so many people of Asian descent that live in that area. But to answer your question, here at Fox Chase and at most places kind of in the Northeast corridor, it's probably around 15 to 20%. Oh, right, I apologize. So the median age for lung cancer that's diagnosed among smokers is about 70 years of age. Now, for never smokers, it's probably about a decade less, so around the age of 60. However, that's the median. So of course, there's half of patients who are older, but then there are a lot of patients who are much, much younger. So we also see patients in their 20s, 30s, and 40s who are diagnosed with lung cancer yet have never smoked.
In the research, have you considered making like an algorithm to come up with like who should be tested? I understand that CT scans and everybody is not feasible, but certainly maybe coming up with a way like, someone like born in the 50s who was exposed to secondhand smoke, or even like you're talking the Asian population, we know a lot of men smoke, maybe not all the women. Is that something that should be thought about within research? I don't.
Yeah, no, these are all excellent questions, and unfortunately, we don't have any clear answers yet. Like my surgical and pulmonary colleagues here have expressed, for those with smoking-related lung cancer, for those with heavy smoking history, the guidelines are pretty clear, and we've already demonstrated that getting the annual CT scans for those patients are helpful. But what you raise is incredibly important, and there is active research, especially in some of the Asian countries where this is even more prevalent, where they're looking at those algorithms, where they're looking at potential screening of patients who may be at higher risk for never smoking lung cancer. But ultimately, we don't have an answer as of yet, but it's an area of active research.
Blood test that you spoke about, would it be something to be done across the population or just in smokers?
Well, I think the goal would be to apply it to a broader patient population. The question then becomes, if you consider a country as big as the U.S., as populous as the U.S., and you want to have a screening test that detects a particular cancer or any kind of cancer, the screening test has to be very effective. It has to be cost effective. And there has to be certain guidelines as to who can or cannot necessarily qualify for it, right? So the scientific question is the first step, establishing that we have something that detected. And then there's more of a societal decision as to how we're going to apply the screening. It might sound simple to offer everybody a low-dose CAT scan once a year, but when you apply it to a country as big as this, it becomes really not a feasible thing to do. So there's a whole science and a whole field of epidemiology and all of that investigates what kind of tests could become available for screening and how do we really apply it. And those are the kind of policy decisions that once we have the scientific advancements, everybody gets involved and we can discuss it. But at this point, that's sort of a holy grail for everybody, having one blood test that's cheap enough and effective enough that can identify it. The reason I brought it up is because we're thinking about participating in some of those studies, but we still have ways to go before we really decide how it's going to be applied to everybody. Sure.
If I could make a point, I also see a lot of patients who get CT scans and they have these abnormalities that may not mean anything. So we talk about low-dose CT scans and how they can help prevent cancer deaths, but it's also important to note that a number of patients who get CT scans who are not in the right group may get them and may get results that prompts further workup and further testing that they may not have needed if they never got the test. So, it's very important to remember that to use the correct test in the correct situation, and also to remember that no screening test gives you a complete answer up front.
Thank you. One more question in the back.
Hello, yes, this is for Dr. Borgai. Back 4 or 5 years ago, immunotherapy was a second line or third line. Today, is it truly first line, no questions asked, all insurance companies go with it, over chemotherapy, if you qualify? And the second part is, I remember you telling me 18 to 20% of the people qualify or have something in their body for immunotherapy with lung cancer. And I happen to have that. But has that 18 to 20% of the people, has that grown?
Yeah.
Or is it still 1 in 5?
Oh, really great question. So, number one, yes, immunotherapy is now being used as our first line treatment for patients who do not have those genetic alterations that Dr. Bode referred to. So we do the first test as the genetic. If there's nothing there, then we go to immunotherapy. Immunotherapy can be given as a single drug, or it can be combined with chemo, depending on the amount of this immunotherapy marker on the surface of the cancer cells. And that is something that we determine also through our colleagues in pathology, in addition to the molecular testing. So there are some patients who would get immunotherapy just by itself, and there are patients who would need chemotherapy added to the immunotherapy. The 18 to 20% that we were referring to are actually roughly around 25% of patients have really high level of that immunotherapy marker on their cancer cells. And we have really good evidence that with a single immunotherapy drug, control of the cancer and survival in that particular group is really, really good. So that's what I was referring to when I was talking about the 20% or so that would qualify. The number has changed a little bit. In the very beginning when the immunotherapy was in the second line space, we thought maybe 15 to 20%. Now for the front line, it's solidly around a third of the patients who come in with a diagnosis of lung cancer who could qualify for a one-drug immunotherapy approach. Yeah.
Hold on, let's wait for a microphone.
Can you qualify, I'll use the word qualify, for the targeted and simultaneously have that amino target, that if you didn't have that, you have that real good amino target?
Yeah, so that's a really smart question. What we know is that some of the patients who have those targeted options, like if you have one of those genetic alterations that we talked about, you could also have a very high expression of the immunotherapy marker. However, that is actually a false elevation of the immunotherapy marker. It's a trick that the cancer cells can play when they have these mutations. Somehow the mutation interferes with that immunotherapy marker. But in reality, immunotherapy does not work in patients that have those molecular targets, and the targeted therapies work far better than immunotherapy. That's our understanding right now. That might change in another 3 to 5 years, but right now, that's where we are. So if you have a target, your best option is a targeted therapy, not immunotherapy, no matter how high the immunotherapy marker is on the cancer cells.
I understand and I agree, but if the targeted, if you build up an immunity to that, do you have that immuno in your back pocket?
So this is a question that we are debating in the world of lung cancer a lot. Should you get immunotherapy if you have a targeted therapy as part of your treatment at some point? I think different lung cancer doctors look at that differently, but the bottom line is that majority of our patients would probably get treated with immunotherapy. The problem is that there is no evidence to suggest that no matter how many treatments we've gone through, that immunotherapy is necessarily going to work on somebody with one of those alterations in the cancer. So if you have those targets, even if we've gone through a bunch of other treatments, there's no way I can promise you that immunotherapy is going to work. You could have side effects from it and not really benefit from it. Yeah,
Right.
yeah, 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 yeah. Yeah, so, yeah, no, as a single drug, it's probably not going to work. So we have a research investigation that actually is looking at a combination of chemotherapy, immunotherapy, another drug. So maybe that way we can take advantage of it, but just as a single drug, I don't think it's going to work in those types of tumors.
I think the other thing to add to this is that the world of targeted therapy is actually getting more and more complex. We used to say, if you have a targeted alteration, which I call the alphabet soup because you have EGFR, ALK, KRAS, BRAF, so it is a little bit confusing, but we used to say if you have most of the time if you have one of these targets, immunotherapy is not necessarily the right approach. However, there are two exceptions to this, one of which is KRAS. So KRAS is actually a target that there's a new drug approved for patients who have a specific mutation called KRAS G12C. It's a drug called sotorasib, which is one of the very exciting advances over the last year. This is a molecular change that we've been trying to target for decades and have been unsuccessful. It's one of the mutations that we've known about the longest in lung cancer, and only now, in the last year, have we been able to successfully target, and now there's an FDA-approved drug. However, this population, for people who have KRAS G12C mutations, often respond well to immunotherapy. So there are, exactly what you're saying, there are some exceptions, but it's very specific and it's very personalized. So I think that's what is amazing about lung cancer over the last decade, is that we have to know so many different things about each patient's individual cancers for us to be able to make the best decisions for them, for their frontline treatment, but also then for their second, their third, et cetera. And I think we're taking all of these things into account in terms of how we best approach patients and their families with this. And I think with that, I'd love to keep answering questions, but I think that we need to make sure that we get to the raffle. So I think we're going to wrap it up, but I love the discussion tonight. Thank you so much for your engagement and your questions.
Thank you. Do you guys have any raffle tickets that need to go in the box before we do the drawings? I'd like to, while we're doing that, thank Dr. Baumann and the members of the panel for their participation, all of you for your questions. As you heard, we're coming to a close, but we're going to do the raffle drawing first. I also have one more announcement. We have one more Together Facing Cancer event this fall, and that's for pancreatic cancer on November 15th. So I want to mention that. We also have our annual Survivor Celebration at the Lincoln Financial Field on November 19th. There are flyers, so please grab one on your way out for the website and more information on that. Before announcing the raffle drawings and all that, I'd like to invite Lisa to come up. Lisa has a poem for us. She's also going to announce the raffle winners.
So as the social worker, I always have to put a personal touch to the end of our evenings because I'm the warm fuzzy and all the emotions. I mean, all the science is great and important, but the reality is we're all human beings and we all have a lot of emotion. So you know, on the night before a big Phillies game that we're all cheering for. I wanted to say I wish for you comfort on difficult days, smiles when sadness intrudes, rainbows to follow the clouds, laughter to fill your lips, sunsets to warm your heart, gentle hugs when spirits sag, friendship to brighten your day, beauty for your eyes to see, confidence for when you doubt, faith so that you can believe, courage to know yourself, patience to accept the truth, and love to complete your life. Thank you, everybody, for being here. You want to pick it?